Hello, hello. Welcome to Chapter 8. This one is, I believe, more educational than the last one, and it probably won't depress me as much, although the conditions that are dealt with in here are quite real. Um, the umbrella concept is mental disorders, and the concept of medical model um, comes up again, um, which is a very strong current theme for dealing with these issues. Um, and, as it says, we'll be dealing with anxiety, schizophrenia, mood disorders, um, the historical impact of drugs, and they focus, as they should, on phenothiazines as having been relatively revolutionary. I was taught uh, neuroanatomy at UCLA by a psychiatrist who compared and contrasted what mental hospitals look like before and after the phenothiazines were introduced, and it was stark, huge change, much apparently more civilized with the modern drugs. They're not perfect. They're not even close to perfect, but it beats what we were doing uh, before. Although the Quakers had a pretty good idea, as I think we'll see. So there's a concept at the end of, in the parentheses, at the end of that first paragraph, non-medical doctorates such as the PhD or PsyD. I'm more used to sticking in periods after the H and D and after the Y and D. Um, and these are the doctorates that are characteristic of clinical psychologists. Early on, certainly in my career, the PhD was the primary degree, but there was, I wouldn't call it a revolution, but there was a change in philosophy that brought the PsyD into the system. You can think of the PsyD as being a bit more like the MD, um, where you're a clinical professional. You're not really a scientist. Um, you are, trained in the treatment of mental disorders, and certainly you learn about neuroscience and stuff, but it's not very much a research degree. Whereas a PhD, there you are a researcher and a clinician. You are both. At one point, they thought that psychology was evolving so quickly, you needed to be a researcher to evaluate all the new stuff so you can do the best therapy. But then they decided that the field had matured and you could be more like a physician who tends to not be a researcher and is just a practitioner. So right now, I'm pretty sure we are graduating more PsyDs in psychology than PhDs. Um, and You can get a PsyD without leaving Scranton, even. Um, so as soon as you start seeing symptoms, the DSM is going to show up again. And one thing to notice about many of these conditions is that, we all get anxious, we all get sad, we all have intrusive thoughts that maybe we shouldn't have. Um, things are often on a spectrum, and if you're going to need professional intervention, you tend to go off the scale. Um, at the moment, we don't have really good biomedical markers yet. There are some, but largely we deal with it in with behavior. So there it is, as threatened for about the third time. The DSM comes up, and there's anxiety and anxiety disorders, and we have anti-anxiety drugs, and I certainly know people who take those. Um, do they cure? Not in the classic sense, but they can have a fairly robust effect on symptoms, and uh, everybody's happier. Psychosis is a major disturbance of normal intellectual and social functioning, and there sometimes are delusions that you're somebody else. And interestingly enough, you're rarely someone boring. You are your delusions are that you're the Virgin Mary, you're Christ, you're Napoleon, and delusions also enhance often your importance in that you're so important. People are trying to control your mind and your thoughts. Um, and this is very disruptive, very real, um, and the DSM rides to the rescue here too. And as I mentioned before, the DSMs originally were heavily psychoanalytic and Freudian, which means not very scientific or evidence based. And as the DSMs go through their iterations, they have become uh, more scientific. And if you look at the anxiety disorders here, you probably heard a lot of these specific phobias, social anxiety, panic disorders, agoraphobia, which is quite popular, generalized anxiety disorder. And, there's a checklist, and you have to have symptoms, and they often have to exist for a certain amount of time. Bipolar disorders, I've known a few of these. Um, they can be very disruptive, and they can shorten your life. Uh, Sometimes they're kind of fun to hang around with, but I wouldn't want to be them. And here's DSM-5 on schizophrenia, delusions, hallucinations, disorganized speech, and that's sometimes kind of funny. They often rhyme a bit, and change topics a bit. I had a roommate in LA who was a schizophrenic who primarily had negative symptoms. He was undergoing therapy, and they were trying to teach him to exhibit normal emotions. And they were teaching him that there were these things called jokes, and people tell a story and then wait, and then you're supposed to laugh, and then you're supposed to tell a joke and wait, and they're supposed to laugh. And he would practice on me when he wasn't turning off all the power to the apartment and setting fire to his diaries. Uh, but I needed a roommate, and he was my roommate. Um, so here's the history. Um, Syphilis can cause interesting cognitive events, and they noticed the correlation between high fevers and reductions in symptoms. Uh, and they were giving malaria to people, and they were sometimes infecting them with filth so that they would have these screaming high fevers. They did this to people who were syphilitic and sometimes people who were schizophrenic. And of course, wealthier patients tend to get better treatment. And barbiturates, which are the last chapter, um, they were often given, which makes the patient easier to deal with, not very good as a treatment, but more manageable. And there's scopolamine. I've done research with that one. And there was a classic World War II German movie where scopolamine was involved, and the Germans were trying to use it as a truth serum. That didn't work very well. Um, yeah, there's an interesting look. Again, we're talking about convulsions, insulin. I mean, we did really rough stuff to schizophrenics. And electroconvulsive shock therapy was tried. Um, I have done ECS, electroconvulsive shock, on animals when studying memory, but when you do it therapeutically, it's called electroconvulsive shock therapy. Um, and I didn't put this link up, but the most famous movie that discussed ECT uh, was One Flew Over the Cuckoo's Nest, where ECT was used. And ECT comes up a few times in this chapter. And there's bipolar. Uh, yeah, inflated self-esteem, grandiosity, decreased need for sleep. This guy would come pounding my door in the middle of the night to go on trips across Maine to visit people. Highly distractible. They like if you have some weird uncle who you went away to the beach and came back and half the house was painted blue and then he stopped. That might be bipolar disorder. Um, the mania can be destructive. As I said, it can be kind of fun. The depression is no fun for anyone. And feelings of worthlessness and excessive guilt. So you can probably guess that suicidal thoughts are going to be part of this, and the people's life can be at risk uh, with this condition or depression. Um, and chemical straitjackets, that was a term that was used early in my career, with the idea being that the drugs weren't really treating the condition. They were just, you know, sedating the patient. Um, we don't use those terms anymore. The drugs are better than that. And the phenothiazines really, really changed things. Um, and the I think the most famous phenothiazine is chlorpromazine. It's still used to some extent today, along with many other drugs that are popular. Um, and there are some terms. Um, Neuroleptics uh, is a common current term. Antipsychotics, that term is used too, but here's Delaware State. We have now achieved the reorganization of the management of disturbed patients. With rare exceptions, all restraints have been discontinued. And that should make you think of chemical straitjacket. They didn't use chemical straitjackets; they used the real deal. Hydrotherapy was used a lot. The book talks about warm hydrotherapy. They also used to use like ice baths, um, and there's electroshock, which doesn't work well at all for schizophrenia. And these developments have vast sociological implications. I believe it is fair to state that pharmacology promises to accomplish what other measures have failed to bring about the social emancipation of the mental hospital. Um, this was big. This was really big, legitimately big. So we have typical antipsychotic drugs, and we also have atypicals. So here's conventional antipsychotics, and if you read down that list, about two-thirds, you find uh, a number of, you know, well, no, I'm sorry, I misread. I thought I saw chlorpromazine, but haloperidol, that's popular, was popular. Uh, so those are typical antipsychotics. And the atypical antipsychotics, which are newer, and there was a local psychiatrist who brought maybe five patients to talk to the University of Scranton students about atypical antipsychotics. Um, with typical antipsychotics, there there can be like a blunting when the drug is working effectively. They're not delusional, they're not hallucinating, but they're a bit blunted. These patients that were on the atypical, I think they were on clozapine. Uh, if you met these people and had long discussions with them, you would never think that they were schizophrenic. And they, to a person, of course, they were on tour, were saying that their lives were a total wreck before the atypical antipsychotics came along, um, and that now they were much more normal. But as you'll see, well, they were normal. But as you'll see in the chapter, these drugs often have side effects, and the side effects affect the blood. And speaking from real experience, if your blood is messed with, you can just say goodbye. And so some of them had to be tested regularly to see if their blood was okay. And what was scary for them is that here you had people who were stone normal, living normal lives, just normal. But every time they went in for blood work, they knew that if their blood came back dysfunctional, the drug company would remove the drug from them, and they'd have to go back into their former lives. Uh, it was definitely a good news, bad news scenario. Um, so there's clozapine being discussed, and when you talk about schizophrenia and the traditional antipsychotics, dopamine, and particularly as it says, the D2 dopamine receptor, seem to be very important. This is one of the reasons that if you take a high dose of these drugs, you look like you have a problem with your dopamine system. And the most common thing to think about here is Parkinson's. Um, and so you have to get the dose right. Um, and the atypicals also have a serotonergic interaction. I'm trying to remember that norepinephrine, dopamine, serotonin, they are all monoamines. But norepinephrine and dopamine are very closely related. Norepinephrine doesn't show up very much in this chapter. Um, but serotonin is a monoamine as well, and that'll be important in discussing depression later in the chapter. And pseudoparkinsonism is a side effect of the traditional drugs. Unethically, there was an institution in Scranton that used to deal with children who had behavioral problems, and allegedly they were able to get a psychiatrist to diagnose a lot of their problem children with childhood schizophrenia, and then they would load them up with like phenothiazines, and then they didn't move so much. So they weren't schizophrenic, but they were behavioral problems. But when you drug them up with drugs that gave you Parkinsonian side effects, they were much easier to handle. This is very unethical, and it has stopped. Um, so nigrostriatal comes up again, and Parkinson's comes up again, and yeah, there's the Parkinsonian side effects. Tremors of the hands sometimes, muscular rigidity, mask-like face. Uh, Reminds me of my former roommate, and a shuffling walk. Um, and nobody likes those drugs. But this doesn't tend to happen with the atypical antipsychotics. Now, tardive dyskinesia is a bad one. And when I was at UCLA, I used to ride the Big Blue Santa Monica bus to get to campus. And oh, geez, there were so many people on that bus with side effects from long-term treatment with traditional anti-schizophrenic drugs. And there, on Mulberry Street, there was a little shop where there was no doubt in my mind that person too had tardive dyskinesia. And this is a really bad side effect. If you're wealthy and you catch it early, you can often deal with it. But if you're poor, and when you're poor, they tend to give you more drug than you need so that you're not a problem. Uh, these symptoms can become lifelong, and late appearing abnormal movements, rhythmic, repetitive sucking, smacking, thrusting out of the tongue, fly catching movement with the arms, toes, and fingers. Uh, it's tragic because you have a patient who's been taking a drug that has been really helping them with their symptoms, and then all of a sudden, if you had to pick one part of you that you didn't want disfigured, it would be your face. And these tics very often involve facial tics. And the people are embarrassed because they're more like us than untreated schizophrenics. And then they have tics, and people point at them and talk about them. It's bad. I'm pretty sure I've given you some stuff, on that. Let's see what we have for your viewing pleasure. Oh, the Quakers. I mentioned them. Um, they really have their acts together in many ways. So this is a New York Times article, um, and treating the mentally ill with dignity and respect from 1988, and their recovery rates were quite good. And they didn't lock people up. They put them in a nice environment. A rural environment with gardens and ponds, and um, it was very caring. And many people came out of that pretty okay. In Pennsylvania, because of the Quakers, uh, had some good treatments for schizophrenia that were atypical in other states. Um, so, and then here's tardive dyskinesia. And this is a video. I think it's a video. Yeah, face of tardive dyskinesia. Again, if there's one thing you don't want messed with, it's not that. All right, so now we're sitting through an ad, and now we are skipping the ad. All right, I can't watch too much of this. And we haven't talked about Tourette's, but Tourette's is real, and it also seems to involve dopamine. Um, and again, what's tragic is these people, not necessarily this particular person, but a schizophrenic effectively treated by drugs, and then they get these side effects, and I just feel so bad. Um, Now, a famous movie about schizophrenia was A Beautiful Mind, and it's pretty well done. Not totally honest in its uh, depiction of how John Nash, Nobel laureate, um, dealt with it, but you know, these people can lead very productive lives if you think winning the Nobel Prize is an indication of being functional and youthful. Um, so, it's a good movie. I'd recommend it. And he came to Scranton, as was common at one time. We used to have a lot of Nobel Prize uh, winners who spoke at Scranton. And I had a seat in the audience about where this camera was from. And this is our provost, uh, and he gave an introduction and mentioned. So he should have had a handler with him. He went up on stage way before he was supposed to, but the provost dealt with it very nicely and mic'd him up, and it was arguably one of the most unusual talks I've ever seen. And he was reading it from that screen, and he was clearly, you know, not normal, but still brilliant. And as I was sitting up in the gallery, I kept seeing this disheveled male get up and bolt out of the auditorium and come back. And it turned out that that was his son. And schizophrenia, like several of the conditions in this chapter, is at least moderately heritable. Um, and Nash and his wife died in a cab accident together, which was probably good. They went together, and he wasn't young. But if you watch this talk, which I'm not asking you to do, he was still pretty unusual. Um, what else have we got for here? Oh, yeah, schizophrenia and smoking. Um, Smoking, nicotine, nucleus accumbens, VTA. Um, Smoking is associated with a number of conditions, and schizophrenics tend to have a high incidence of smoking. And whether that's evidence of self-medication, I don't know. But this little article, I'm not assigning it, just showing you stuff from St. Patrick's Day. Um, and e-cigarettes can help uh, schizophrenics stop smoking, which is good. Um, and then the last two are for later in the chapter. So now we're back over here. So tardive dyskinesia, Parkinson's, dopamine. Hopefully all this stuff is starting to click. Like you're seeing the same things repeating over and over. And yeah, there's some research on the treatment of schizophrenia and treatment of children and the elderly. Uh, I think there's some tendency to over medicate those two populations, but you never know. And antidepressants. This is an important segment. It teaches you about the brain and also about therapy. So monoamine oxidase inhibitors, abbreviated, it has to be or some way. Yeah, no, it's not. They abbreviate monoamine oxidase, MAO, but they don't throw in the I for inhibitor. Monoamines we've been talking about, norepinephrine, dopamine, serotonin, and they come up with a drug to treat TB, and it seems to elevate mood. And it they can be, that's a family, MAOIs, monoamine oxidase inhibitors. Let's talk about that for a second. Monoamine oxidase is one of the ways we break down, that is, turn off monoamines. Now, if I give you a drug that inhibits turning something off, it stays on. So these drugs increase activity in the monoamine systems. But there can be side effects. And here's a dietary amino acid, tyramine. And people who take MAOIs have to watch their diets, or they can get hypertensive spikes. Now, unfortunately, physicians tended to not explain this to the patients all that well. They were affected by trendy diet. Diet can affect your microbiome, can affect your brain, and they would believe that the dietary restrictions they were on was to help them not be depressed. No, the restrictions were there to keep them from dying from side effects, and occasionally they would say, "Well, I feel pretty good right now, and if I feel bad, I will just go back on my diets again." Well, The cheese reaction can kill you. Uh, your blood pressure can go to the moon. Aged cheese, Chianti wine, smoked or pickled fish, many others. So there's some MAOIs, and they were followed by tricyclics, which also affect monoamines, but in a different way. MAO inhibitors inhibit the destruction of monoamines. Tricyclics block the reuptake of monoamines, which is how they're turned off. So in both cases, you're blocking turning something off. And they weren't magical, but they could be pretty effective. Imipramine is a big name there. And then, of course, what's popular now, SSRIs, selective reuptake inhibitors. And if they're selective for serotonin, they are SSRIs, selective serotonergic reuptake inhibitors. And the most famous SSRI is about two-thirds of the way down there, fluoxetine, Prozac, Paxil, Zoloft. These are big name drugs. They're popular. Um, and one thing about Prozac in particular is that it has a very long half life. Uh, and sometimes these drugs seem to require the brain being under the influence of the drug consistently for long periods of time. And the beauty with Prozac is you miss a pill, and by the time you take your next pill, the half life has not passed, and the brain has been consistently under the influence of the drug. The timing of how these drugs affect depression are very interesting. And Wellbutrin, I know a few people who've taken that. That's used sometimes to help people stop smoking. In addition to antidepressants, depressants. And there's tricyclics, there's imipramine. Um, it doesn't help psychosis, but it can help depression. Um, so there's a discussion again about how monoamines are important to these effects. MAOIs or tricyclics uh, mean the monoamines last longer and have a greater effect. And there's norepinephrine. Norepinephrine is thought to be important for the antidepressant effects, at least often. And then there's SSRIs and Prozac, which became wildly uh, popular for the treatment of depression. Um, and it's not the only drug. There are a number of drugs, and they're not magical, but they can certainly help. And yeah, medications added to medications. This can get very complicated, and it means that the therapist, the physician, PhDs and PsyDs in most states don't have the legal ability to prescribe drugs, but psychiatrists will often have PhDs and or PsyDs in their practice, and they will consult with them. Um, so you start taking multiple drugs for the same condition, you really have to have a physician who knows what they're doing and is very attentive to what's going on with you. And there's lots of drugs, FDA, lots of drugs. Um, and every time we've talked about drugs, we've come up with unintended consequences. And the need to do these studies, uh, I would say double blind, uh, it's the gold standard for whether something works. And these things The placebo effect is real, and you think you're taking something, and the belief that you're taking something that will help you can help you. And the question here has to be, do these drugs work better than placebo? And I would say yes, but not like wildly uh, better. And more discussions of the drugs and different types and whether they work. Um, this is a good chapter, and no doubt you know people on these drugs. And here's ECT. ECT has a bad rep. One Flew Over the Cuckoo's Nest, again, is the classic movie, which gives a negative portrayal of ECT. But boy, one thing that's odd about the pharmacological treatments for depression is it often takes weeks before uh, the therapeutic effect comes through. And unfortunately, sometimes as people are getting better, their mojo comes back and they decide, well, I don't need this drug anymore. Oh, yeah, you do. It's what's helping you get better. And of course, if you're suicidal, weeks of being suicidal can literally be life threatening. We don't fully understand how ECT works, but oh, geez, does it. This can work really quickly. Um, and there's a discussion of depression may take 3 or 4 weeks. ECT, bam. Of course, it is a bam. Okay, so lithium, I know people on that, and that was taken uh, quite a bit uh, for various purposes, but the major purpose for taking lithium now is bipolar disorder. Let me see. Well, I know I have some stuff for you here on lithium. This is an interesting twist. People get freaked out when we put uh, things in drinking water, but lithium comes from the earth. And, this is a 22 article. Lithium in drinking water linked with lower suicide rates. That sounds good. And it's naturally occurring lithium. It's it's from the earth. It's I guess it's organic, and that can be a positive. Now this just came up this week. I love these shows. I'm not assigning any of these. These are all just to hopefully keep you interested. So that's a very good piece, and their educational pieces are often extremely good. Um, and I knew two bipolars in graduate school, and lithium really helped both of them. Some people who are bipolar, they really enjoy the mania, and lithium tends to clip that off. So one of these guys used to come off his lithium just so he could go through a manic phase. That's really not a good idea. I remember there being some evidence that if you took a rest from lithium and your bipolar disorder came back, the lithium might not work again after you went back on it. Um, and so if you're taking it, I would take it. And you see down below, there are anticonvulsant drugs that are also used to treat bipolar disorders. Um, and it's interesting that something that treats epilepsy can also treat bipolar. Um, that has to be trying to tell us something. We still don't fully understand it. And, consequences as we've used more drugs, the number of people inpatient has gone down quite a bit. Um, and there's again a discussion of the ethics and the medical model, and uh, you know, patients have rights, and do we have a right to medicate them? And they have protections. Usually, they have to be a threat to themselves or others. So here's the summary. The medical model has been criticized. The book is prone to that, but psychotherapeutic drugs certainly have some value. Diagnosis, DSM-5, antipsychotics like chlorpromazine, revolution in mental health. And again, I knew a psychiatrist who lived through this, and he said it was dramatic, not unlike that quote from the psychiatrist from Delaware. Um, so these drugs can definitely affect the symptoms of schizophrenia. They don't. It's not a chemical straitjacket. It really does help the symptoms. But because you're messing with dopamine and Parkinson's comes from dopamine, you can have some side effects that are Parkinson's related. And then we go into antidepressants and MAOIs. I wish they would use the I. Um, I always say MAOIs, which means you can't destroy your monoamines with monoamine oxidase, and therefore you have more monoamines. And the tricyclics block reuptake, which means the monoamines have a longer life. And so those two are congruent. And then you have the selective reuptake inhibitors. And if they're serotonin, you have the SSRIs. And again, you're speaking with your own serotonin, but it speaks more loudly. Um, and then there's the discussion of lithium, and very interesting about the suicides. Um, I'm intrigued. I don't think I would add lithium to the water, but the correlational data are interesting, and people in mental hospital numbers have gone down, and there's some review questions. So I apologize for my voice today. I don't know what's going on. It's got to be this break that I haven't been lecturing enough. I hope I have been understandable. And I hope you've enjoyed this. And I would definitely recommend you you look at that SciShow piece on lithium. But none of that is testable. It's just for your viewing pleasure because we want this course to be fun, right? So until we meet again.